Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 505 of our pharmacotherapy series, which majors in anemias. The first case reads, JYT is an 18-year-old man with sickle cell anemia who presented to the emergency department with rapid onset of abdominal pain and shortness of breath. During early childhood, he experienced several episodes of acute pain, swelling of the hands and feet, and jaundice. 3 years before this admission, JYT required a left hip replacement due to osteonecrosis caused by sickle cell anemia. Recently, frequent blood transfusions have reduced the frequency of sickling crises. Physical examination reveals JYT as a thin black man in acute distress and with scleral icterus. He has a pulse of 118 beats per minute, a respiratory rate of 17 breaths per minute, and a temperature of 98.8 degrees Fahrenheit. His lungs are clear, splenomegaly is noted, and a chest radiograph reveals only cardiomegaly. A CBC is obtained. Notable results include the following: a hemoglobin of 5.9 grams per deciliter, a hematocrit of 27%, a WBC count of 5,000 per microliter, a platelet count of 335,000 per microliter, a reticulocyte count of 1%, bilirubin of 5.8 milligrams per deciliter, serum creatinine of 3.1 milligrams per deciliter, and a blood urea nitrogen of 54 milligrams per deciliter. The peripheral blood smear shows target cells with an occasional sickled cell. So my first question to you reads, what signs and symptoms are consistent with sickle cell anemia? What is JYT's current complication? Vaso-occlusive crisis, or sickle cell crisis, is caused by severe pain and organ damage. These may be precipitated by many factors including hypoxia, dehydration, infection, and pregnancy. Based on the presence of splenomegaly and anemia with target and sickled cells, JYT currently is presenting with an acute splenic sequestration crisis. Acute splenic sequestration is caused by the trapping of RBCs within the spleen. This causes splenomegaly and progressive anemia. The low reticulocyte count is consistent with acute sequestration because a reticulocyte response would be expected if the anemia had developed in recent days. JYT's inadequate reticulocyte response may reflect rapid progression of the anemia, HPV-B19 infection, or a blunted EPO response secondary to compromised renal dysfunction. My next question to you reads, how should JYT be treated? JYT's signs and symptoms are sufficiently serious to justify transfusion therapy. In addition, JYT should be adequately hydrated, considering his elevated serum creatinine and blood urea nitrogen. Because patients with sickle cell anemia often lose the ability to concentrate urine, they may become dehydrated, which further contributes to cell sickling. The pain associated with a crisis typically lasts at least 2 to 6 days and should be managed with analgesics including parenteral opioids for severe pain. Pain control should be aggressively instituted for JYT's comfort and should be continued for a few days after hospital discharge. It is important not to withhold opioids because of a fear of addiction. Splenectomy may be indicated in instances of severe splenomegaly, repeated infarction, or pain in adults, and it is indicated when crises occur in children. Those patients with sickle cell anemia who are bedridden should be placed on chronic heparin therapy to prevent vascular occlusions and deep vein thrombosis. JYT presents to the emergency department 3 months later with complaints of fever, cough, and severe throbbing pain in his chest and abdomen beginning 2 days prior. This is his third admission within the last year. Notable laboratory results include the following: a hemoglobin of 6.6 grams per deciliter, a hematocrit of 18.9%, a platelet count of 218,000 per microliter, WBC of 19,700 per microliter, bilirubin of 4.7 milligrams per deciliter, and a serum creatinine of 1.1 milligrams per deciliter. His chest radiograph shows diffuse interstitial infiltrates in both lung fields. His vital signs are as follows: a blood pressure of 98 systolic, 53 diastolic, a heart rate of 102 beats per minute, a respiratory rate of 23 breaths per minute, a body temperature of 101.4 degrees Fahrenheit and oxygen saturation of 93%. So my next question to you reads: what complication of sickle cell disease is JYT experiencing and how should he be treated for this condition? JYT is experiencing acute chest syndrome, a leading cause of morbidity and mortality in patients with sickle cell disease. The diagnosis of acute chest syndrome is determined by new pulmonary infiltrates on chest radiograph with one or more of the following: fever, cough, worsening anemia, and pleuritic or non-pleuritic chest pain. Patients may also experience shortness of breath, rales, hypoxia, and wheezing, more commonly in children. Causes of acute chest syndrome include pulmonary fat embolism, pulmonary infarction, and infection. Commonly implicated organisms include Chlamydia pneumoniae, Mycoplasma pneumoniae, Streptococcus pneumoniae, Haemophilus influenza, and various viruses. The primary goal of treatment is to prevent progression to acute respiratory failure. Therefore, treatment should involve pain management, hydration, oxygen supplementation, incentive spirometry, antibiotics, and, potentially, transfusion. Optimal pain control and incentive spirometry are important to prevent hypoventilation and atelectasis, as well as to increase patient comfort. Oxygen should be administered nasally to patients who are moderately hypoxemic, that is an oxygen saturation, 92% to 95%, PaO2, 70 to 80 mm of mercury, as JYT is. Patients who are febrile or severely ill should receive IV broad-spectrum antibiotics as it is difficult to exclude bacterial causes of acute chest syndrome. Empiric antibiotic therapy should take into account the commonly implicated organisms described above. Transfusions are used to increase the oxygen affinity of blood and are indicated in patients with hypoxemia or whose clinical status is deteriorating and with a hemoglobin greater than 1 gram per deciliter less than baseline. JYT should be monitored closely for deteriorating respiratory function and should receive transfusions if his clinical status does not improve. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 506.